So, Dr. Chang, can you speak to any unforeseen or outdated practice-related barriers that may actually hinder your work and that of your colleagues as it relates to understanding CLL dosing?
Yeah, so even though most of us in the CLL community have already moved to these novel targeted therapies, we do occasionally still see patients that are referred to our centers who have undergone frontline chemoimmunotherapy, which for the vast majority of the patients nowadays, there really shouldn't be an indication for that sort of treatment anymore. And so I think one of the main limitations is that we are using or at least some providers are using frontline chemoimmunotherapy and not necessarily, and by doing so, they negate the great benefits that these novel targeted therapies have, particularly again in frontline setting. Um, Other unforeseen or outdated practices might be related to how we optimally mitigate the tumor lysis risks. And also, occasionally, we might see some referrals from community practice physicians with patients who have CLL and they have recurrent cytopenias or persistent cytopenias while on therapy, and they attribute it to toxicity of the therapy, where in reality, if you do a bone marrow biopsy, they might be having a lot of disease in the bone marrow, and that might be the answer for this particular um, so-called toxicity, but in reality, it's actually disease progression.
So, Dr. Ermann, based on what Dr. Chang just shared and some of these sounds like maybe knowledge or practice gaps, what are some solutions? How can we begin to bridge these gaps so that patients are receiving the best of the best with regard to therapy?
So there's a little bit of, I would say that there can be a little bit of delay in certain providers changing their practice to the current kind of academic approach. I think that from what I've seen, the best way to manage it is when patients are seen in the community by providers. I personally have quite a good relationship with many community providers in the community setting, and I encourage those providers, if they get a new patient diagnosed with CLL, to recommend a CLL consultation. And I would advocate that the patients also kind of look into their disease and see whether or not a CLL consultation with an expert in the field of lymphoma or CLL may be good for them. And in those ways, I've seen, personally, I co-manage many patients across the Western United States. They're still able to be seen by their local oncologist and also be seen for consideration of clinical trials in the CLL space when indicated for their more rare disease. So I do think it comes from both providers and patients, but I think empowering your patients, letting them know that there are other doctors who may specialize in the condition that they have is really important. And when patients do that, not only are they happy, their local oncologist is happy. It makes it kind of better for everyone.